Hello and good day everyone. Welcome to our channel, Hermie and Angela. If you are new to this channel, welcome. A brief introduction about myself. My name is Herminio. You can call me Hermie for short. I was born in the Philippines. I'm a Filipino. But for the sake of our international viewers, I'm going to be trying to speak in English most of the time. That way it will be easier. But pardon me in advance if I have some grammatical or language mistakes along the way because I'm not the expert in the language, but I'm conversant. Anyway, more about myself. I'm in my early 50s. I'm currently living in Canada with my wife, Angela. We have no kids. We moved here when I was 35 years old. So most of my life, I was born and raised in the Philippines, like I said. Yeah, so welcome. And the intent of this channel is to share with you my cancer journey so far, and also share some of my hobbies, including singing and gardening. Yeah, thank you again and welcome. Now, before I proceed, I would like to say hello to my relatives, my family back home in the Philippines. Thank you for watching and keeping updated on my journey. Also, I would like to say hello to my friends of old, like maybe friends in kindergarten or elementary, which I haven't seen in the last, 35 plus years. So hello to you all. Thank you for reaching out to me. Thank you for your encouraging words, and thank you for following me, and thank you for praying for me, for my health, for my family, and I really appreciate everything that you guys do. Thank you very much. So as the title of this video suggests or say, I am now on my third line of treatment, chemotherapy, and more about that later. But for those of you who are in the medical field, you probably know what it means. So before delving into that, last week I had my last CT scan done and blood work. That was June 18, 2025. And yesterday I had a conversation with my oncologist and my naturopathic doctor about it. And briefly, I'm gonna write down here the diagnosis or the latest, right? So male, my age, with PMMR/RAS wild type, metastatic sigmoid colon cancer to the periaortic, retrocrural, and left supraclavicular lymph nodes with primary in situ. That means primary in situ. It means the cancer is still in the original site where they first found it, like in my colon, sigmoid colon, and my lymph nodes. It hasn't spread to other organs like my liver, lungs, bones. So it hasn't spread up to now. And then furthermore, it says here, progressed on FOLFIRI and panitumumab, FOLFOX, and bevacizumab. So those are my first two lines of treatment. And when the FOLFIRI first and panitumumab, and then second line of treatment, FOLFOX and bevacizumab. More about that in the chart that I'm going to present with you later. So about the CT scan, so it's a mixed result, right? But I'm not gonna tell you all about the details, but basically the impression written here is 2 new pulmonary nodules in the right lower lobe as described above. So this may reflect endobronchial impaction. So they are not sure if it's a cancer, if it's a tumor, or it's just a endobronchial impaction, meaning maybe it's bronchial bronchus or bronchial is one of the airwaves in our lungs, right? Or air paths, and then there might be some, when you say endobronchial impaction, it might be a dried mucus that's blocking those two airways. So they're not sure what it is yet, but hopefully it's not cancer, and it recommends a follow-up. And second point in the impression, the patient's known sigmoid malignancy is grossly unchanged. So it's still the same as last time, as last scan. And then third point, retroperitoneal lymph node posterior to the left renal vein has decreased in size. So it was before 16 by 10 millimeter. Now it's 8 by 12 millimeter. And then the other one is single superior rectal chain lymph node has slightly increased in size. So it was, before it was 7 by 5 millimeter. Now it's 10 by 6 millimeter. So I'm guessing, you have a node like a bean shape. You cut it across the largest part in the middle, and then the cross section, that's probably the diameter, that's the diameter of the two axes. If you imagine an oval, you have a vertical line axis and the horizontal axis. So that's the diameter that I'm mentioning. So some increased, some decreased. So we don't know what it means, but basically the malignancy in the sigmoid, which is thickening of the sigmoid walls, is grossly unchanged. So I don't have any blockade. They found nothing in the other organs, like in the lungs, the liver, the gallbladder, kidneys. They are all clear so far, which is good, right? Now moving on to the my tumor marker, which is the other tool that the medical team is using to measure or to track my progress. So here I will be presenting to you a chart and what that means so far. So what we are looking at here is the histogram of my tumor marker. You read it from left to right. The blue line represents the CEA tumor marker, and the orange line represents the CA-19-9 tumor marker. So, cancer secretes certain enzymes in the bloodstream or proteins, and so through blood work, through blood testing, they could measure it in the lab. So my blood work was done every 2 weeks. Yeah. The vertical axis on the left is the measurement, and the horizontal axis on the bottom is the data point. So the measurement is also shown on the data points along the lines of the chart. In BC, British Columbia, Canada, the normal range for CEA is below 5, and for CA-19 is below 35. So as you can see, I'm above those limits. So it's a sign of its cancer. So on the first portion on the left between the two red lines, that's my first line of treatment, consisting of FOLFIRI and panitumumab. FOLFIRI, I took irinotecan, 5-FU, fluorouracil, and panitumumab. So it lasted about 10 months. So it started around 490. Actually, before that, I had tumor markers measured, but they are counting it from this point, from 490, and it dramatically went down up to 72 by around August, and then it started rising again until early November of 2024. So, and the CEA is also exhibits the same pattern. Started high and goes down, it goes up. So at that point, when the tumor marker is rising, that's when they consider it that it has progressed, meaning the treatment is no longer working. So it's time to change the treatment. So for my second line of treatment, it consisted of Folfox and bevacizumab, or Avastin for bevacizumab. Folfox is oxaliplatin, and also with fluorouracil or 5-FU, and bevacizumab. So when my CEA was at 238, that's when we started the second line of treatment, and it worked again. It went drastically down until it went all the way down to 68. But then from that point, it started rising slowly. However, my CA 19-9, sorry, it drastically went up to 494, right at that third red line, vertical red line on the right. So it's the CEA is still at the low point, but my doctor is suspect that it's gonna steadily rise or rise again, similar to the first line of treatment. So that's when we decided to now switch it to the third line of treatment, which consisted of flufluoridine and tipiracil plus bevacizumab. It's still going on bi-weekly, so it's starting on next week, July 3rd. So we don't know, but we pray and hope that it will work, and it will continue to work for a long time. So that was my blood work so far. Yeah, so I'm starting my third line next week, July 3rd of 2025. Just so you know, by the way, in Canada, in general, hospitalization, treatment, surgeries, name it, is covered by the provincial healthcare system, as long as it falls within the what you call this, funded therapy, meaning those drugs that I mentioned, those chemotherapy drugs are funded. You don't have to pay out of pocket. Of course, there's more drugs, but those are in the high, very expensive ones, and they are excluded, and you have to pay out of pocket for those. So hopefully you have enough coverage from your personal insurance, your critical illness, to cover those, or your savings or investments, whatever you have. If you decide to, or if it's deemed that you might need those chemo drugs in the future. Yeah, so in general, Canadian healthcare is free to the public. If you are even if you are a temporary worker, or on a visa, work permit visa or study visa, here in BC, you don't have to pay for the premium healthcare. It's covered by the government. Yeah, and it's probably where your taxes go. Some of your tax money go. Yeah. So now, what would be the next steps down the road? My oncologist suspects that because I have progressed on those first two line of treatment in a very short period of time, he suspects that I have less than a year, which is at first it sounded as a shock, but I'm handling it well. My wife and me, we're handling it well. We know that as long as you're breathing, as long as you're moving, you're alive, you wake up every day, there's a blessing waiting for you. And if you keep on praying, if you keep on trusting the Lord, everything can change in an instant. Right. So my oncologist did mention to me about thinking about having a will and testament. in place in case, you know, something happens. Or he kind of mentioned, like, while your faculties, your mental faculties are still intact, you know, how do you want to be, you know, where your assets would go, who would be your, you know, beneficiaries. Me and my wife, all of our accounts, bank accounts, the title on this on our mortgage, we are joint. So except for the recent car that we bought, so you might still have to work on that. The advantage of that is if somebody passes away, then there's less complication in regards to your estate or whatever you have left behind. Otherwise, if you don't have that in place, then your assets will go into probate. So whereas if you are joint account, you have a joint account, it's automatic. You don't it won't go into probate. And also, to cover more of that, you need to have a will and testament in place. And also, you need to identify an executor. In case, you know, both of you or both of us pass away, we need to have an executor, meaning the person who are close to us, whom we can trust to execute the will. And on top of that, a backup executor in case the executor, the primary executor, you know, pass away too. Like, for example, you travel together and that person unfortunately passed away, then you need to have a backup. So it's not only for people who are dealing with serious or chronic conditions or illnesses. It's also a good way to protect your assets, even if you're not sick. Like, all your hard work for so many years, you know, you would want it to be passed on to your loved ones, right? Or go into somewhere else, like a good cause, right? So it's good to have that in place. So that's one that he discussed. And the other thing is, he suggested that start thinking about DNR. DNR meaning it's an abbreviation for do not resuscitate. Did I say it correctly? Do not resuscitate, meaning, for example, you are already in hospice care, which is another program here in Canada, where if you're very grave and sick, and you could go into hospice care, meaning it's a place where, you know, basically they will be where you will be spending your last days, and a nurse will be taking care of you. And in case something happens, like, for example, you have a cardiac arrest, then they can either resuscitate you to keep you alive, or you could also opt not to have it done to you, because the consequence is, most of the time, my oncologist said, and my naturopathic doctor said, yeah, they could resuscitate you. You could survive whatever it is, pulmonary, cardiac arrest, or heart attack. But you'll probably be bedridden. You're looking at the machine or tubes that will keep you alive. Do you want to see that? Or do you want to experience that? Or you can simply say to them, I'm okay. Please do not resuscitate me in case something happens. So that's something to think about, and everybody is different. Yeah, so those are the things that he mentioned to me. And last thing is, so what if the third line doesn't work? Of course, it's not the end of the line. It's not the end of the road, right? It's just that it's not going to be covered anymore. But there are options. And another thing is, he's referring me, here in BC we have the so-called personalized oncogenomics. Yeah, it is more detailed. Like, the way it works is, you will be referred by your physician or your oncologist to this program, and basically it's a personalized oncogenomics, meaning they would do a whole genome analysis. You know, the genome is a DNA that has a genetic code, right? They would take a biopsy of your cancer cells and then your normal cells, and they would map it to compare what is driving the cancer. So between your cancer cells and your good cells, what is the difference? And from there they could potentially identify tailored fit treatment for your case. So it's individualized, right? So these first 3 lines of chemotherapies are standard practice, but this one is more detailed. It's personalized to your case, and the end is they could probably come up with a recommendation for treatment with still the same standard line of chemotherapy, or they could suggest a non-funded available chemotherapy drugs, which are probably going to be very expensive, or they could recommend off-label drugs. I've gone through the website, and one of the off-label drug that was recommended or identified for a certain individual was metformin. It's an off-label drug. It's a drug that is not normally used for cancer, but they have found it to be could work towards your particular gene cancer mutation or whatever they found out. So that's a good thing. So my doctor is enrolling me into that, and hopefully, I don't know the timeline yet, but he has put forward the referral, and I agreed to go through it. And so, hi, so if you have reached this point of the video, I thank you very much for watching. And before I end, I wanted to just emphasize that the purpose or the end goal of this blog or this video is to encourage and to share information. And in ending, I would like to give you or share with you a quote from the Bible. It's from Philippians chapter 4, beginning at verse 4. Rejoice in the Lord always. Again, I will say, rejoice. Let your reasonableness, or in other words, gentleness, be known to everyone. The Lord is at hand. Do not be anxious about anything, but in everything, by prayer and supplication with thanksgiving, let your requests be made known to God, and the peace of God, which surpasses all understanding, will guard your hearts and your minds in Christ Jesus. Amen. So keep on praying. Do not be anxious about anything. Let your requests be made known to God. And I hope you have a blessed day today, wherever you are, and see you in the next video.